Well, good evening, everybody, respected members on dais and my colleagues. Today, I would like to talk on recent advances in tuberculosis. Now, tuberculosis is a disease which is like age-old disease everybody is aware of. Like 4 years back, such topic would not even exist because there was no advances in TB management which has changed since 1962. 1962 was the year when we had last new TB drug. So last 50 years, there was nothing new to talk on. It is all because of late Dr. Modi's innovation and excellence that he thought of just adding pepper, that is your piperine, to something which is existent since last 50 years would change the management of tuberculosis in the present decade. Now, advances in TB management deals with three phases. One is a treatment phase, a diagnostic phase, and a preventive phase. In treatment phase, we are facing a lot of problem with drug-resistant tuberculosis infection, the MDR TB, which is on rise. Then you have drug-susceptible TBs. We have no new drugs till date which are approved. We are all using some of the second-line reserve drugs to manage our primary TB infection with some fear or some assurance that it will do good to our patients, will cure them much faster. But that is not the true sense. Then you have some new changes in diagnostic modalities like gene export, which has again changed the scenario of tuberculosis. Vaccination are still very, very infant in our fraternity. Now, road to elimination would be first to stop transmission of TB. If you want to eliminate tuberculosis, if you want to eradicate tuberculosis, the first step would be treat your patients adequately. Primary drugs still are the best drugs, rifampicin, INH, pyrazinamide and ethambutol. We all fear toxicity of TB drugs. Rifampicin-induced hepatotoxicity, GI intolerance, most common causes of drawbacks for our patients. They stop therapy, they go to somebody else who change the regime, again they go to somebody else. In that rotation, you have an MDR TB. So MDR TB is predominantly a disease which is, I take the responsibility, my colleague should take the responsibility, some responsibilities with the patient also. So we all three of us are at fault for creating drug-resistant tuberculosis. You have to neutralize latent infection. That is, we all are MANTO positive. Majority of us MANTO positive. We carry latent infection in our body which can activate at any time. To prevent that, at present we don't have any good armamentarium in our fraternity to treat latent infections. So the most important is to treat the active TB infection. Active TB infection, whether it is a pulmonary infection or an extrapulmonary infection, we have to be more cautious in treating pulmonary infections because these patients are open to the society. They will spread infection to you, your colleagues, to the society, and that will continue the chain of the bacilli. So most important is to treat the active TB infection. Now, a couple of new drugs are in pipeline. One of them is bedaquiline and delamandate. These two drugs are approved by US FDA and Europe FDA, but they are reserved for extensively drug-resistant population, which we normally don't see. We reserve ourselves to active TB infection as a sensitive bacilli and a drug-resistant infection. Extensively drug-resistant infection are managed by institutes, and these patients are enrolled in these trials, and it is given only under supervision. We cannot use these drugs in our routine day-to-day practice. Now, these two drugs, both of them are bactericidal drugs. They act on rapidly multiplying bacilli. The aim of the treatment is to reduce the dose of therapy. Now, dose of TB therapy is minimum 6 months. Maximum it can go till 8 months, 9 months, or in some extent to a year. We want to reduce this therapy to, say, last 4 months or 3 months or even less, so that the compliance is more better and the TB is treated more quicker. Major drawback of TB treatment is the duration of therapy. First 2-3 months, everybody is well with the treatment. Subsequent 3 months is all dropouts. All erratic combinations come into picture. Rifampicin only, INH only, some quinolone somewhere. All this disturbs the entire 6-month schedule. So the aim of the treatment with these newer drugs would be to reduce the duration of therapy to 3 months or lower. Now, these are the new drugs which are used for your extensively drug-resistant tuberculosis infection. Citazolid, that is a linezolid analog. Now, linezolid presently is used for treatment of MDR and XDR infections. You have a specific analog of linezolid, a bactericidal drug called citazolid, which is being studied for extensively drug-resistant tuberculosis, more specific for tubercle bacilli. Now, linezolid is used for gram-positive infections, have high degree of resistance in the society. Now, we have citazolid, which will be more specific towards Mycobacterium. You have analog of ethambutol, an age-old molecule. Now, this analog of ethambutol is a bactericidal analog. The present ethambutol is a bacteriostatic drug. So, more bactericidal drugs which we have in our armamentarium will reduce the therapy of treatment. The only two bactericidal drugs right now we have is INH and rifampicin. Pyrazinamide and ethambutol are bacteriostatic. Streptomycin is again a bactericidal, but yes, it is out because of very high degree of resistance and to some extent toxicity. All other drugs, that is your ethionamide, cycloserine, PAS, are second line drugs, bacteriostatic, technically weaker drugs, reserved for your drug resistant infections. You have only moxifloxacin, a quinolone which is approved to be used for MDR TB, which is a bactericidal drug. That is the reason why your MDR treatment is for 2 years and your normal TB treatment is for 6 months. The second line drugs are again technically weaker drugs, take longer time to act. These are some of the again newer drugs like Pritomandid, which are being approved for usage in extra pulmonary and extra drug resistant, that is extended drug resistant tuberculosis. Now, this all is theoretical in trial phase. Now, the present scenario would deal with rifampicin, INH, pyrazinamide, ethambutol, the classical 4 drugs used since last almost 50 plus years for treatment of tuberculosis. Now, we have a lot of limitations of rifampicin. Everybody feels rifampicin is toxic, vomiting, nausea, GI intolerance, hepatotoxicity, raised liver enzymes. Most common thing, patients drop out. We also fear adding rifampicin would again cause some hepatitis. Now, taking this picture into account, this innovation was made that to add piperine, which is a bioenhancer, would reduce the dose of rifampicin. Now, rifampicin standard is like 300 milligram, 450 milligram, or 600 milligram. We cannot cross 600 milligram irrespective of the patient age. Now, out of that 600 milligram rifampicin, over a period of time, rifampicin will induce itself. It will eat up itself over a period of time. So that is why you find some patients X-ray improve in 10 days, some X-rays improve in 1 month, and some X-rays improve after 2 months. Some X-rays improve after 4 months of therapy. That is because of individual auto-induction of rifampicin. If you start taking rifampicin daily, over a period of time, after 14 days, the rifampicin levels will start falling. It will eat up itself. It is called as auto-induction. Now, to prevent auto-induction of rifampicin, the concept of adding a bioenhancer called piperine was used. Now, piperine is nothing but an extract from black pepper, commonly called as murri, the black pepper. Now, this piperine will prevent the cytochrome 450 system. Auto-induction of rifampicin is prevented, and you can actually reduce the rifampicin dose by half. So, 450 milligram would become just 200 milligram. So, now you have just 200 milligram of rifampicin going into your body. So, considerably less side effects, less GI toxicity, less risk of hepatitis, and improved patient compliance. The major fault in TB treatment remains in the compliance period when you start vomiting with rifampicin and INH. So to take care, you have a poor GI intolerance, low bioavailability because of auto-induction, and subtherapeutic serum rifampicin levels over a period of time, which could lead to drug-resistant infections. So all these shortcomings because of rifampicin-induced side effects, I would not call it toxicity or adverse effects, these are just side effects. You have a combination called as Rizorine, which is a combination of piperine. It reduces the dose of rifampicin to half of it. So the compliance is very good. Compliance as far as side effects of GI are concerned, there is nausea, vomiting, and hepatitis, or almost 1/10 compared to the standard 450 milligram rifampicin. Now, Rizorine lowers incidence of gastrointestinal side effects, better tolerability, and improved patient compliance. Compliance is very important because you are treating patient for next 6 months, 9 months, or 1 year. Benefits of adherence to the therapy because of less side effects is more over a period of time. Every patient leaves TB treatment fearing side effects. The moment you start AKT, first thing is patient will say liver kharab ho jayega, liver ka problem aega. They are also now aware that taking AKT will induce some GI problem. Some patients will have nausea, some people have vomiting, and some people will have hepatitis. So now Rizorine has its place in therapy, treating pulmonary and extrapulmonary infections wherever the patient's weight is between 35 to 55 kg, because this formulation is studied with 450 milligram of rifampicin. You cannot extrapolate it to 600 milligram of rifampicin. So if you have a patient who is weighing 65, 70 kg, you would probably classically use 600 milligram rifampicin. Patients who are between 35 to 55 kg, the vast majority of the TB populations, more than 90% of the population would fall into this category, would benefit from this combination of adding 10 milligram of bioenhancer called piperine that will prevent the auto-induction of rifampicin and extend the level of rifampicin over a period of time. It is specifically indicated in high-risk individuals like alcoholics, elderly, malnourished patients, and patients with pre-existing liver disease. Any patients who is an alcoholic, you're always worried about AKT, hepatitis. Same is with malnourished elderly people and chronic liver disease. Now, newer anti-TB regimes are required to reduce the dose of therapy, as I earlier said. 6 months is for standard sensitive bacilli. 24 months or 2 years is required for an MDR-TB. An MDR-TB cannot cure himself before 2 years of age. 2 years is required to complete the entire therapy. Newer forms of therapy, the drugs which we showed earlier, would reduce the treatment to say 4 months and less to improve the patient compliance and faster cure. Moxifloxacin is a good second-line drug, an excellent second-line drug, and should be reserved as a second-line drug. We all make a mistake of adding moxifloxacin to first-line drugs with an intention that it will cure the patient faster. Because we have a wider experience with quinolones, we are more comfortable using quinolones. We feel that, okay, patient is not doing well with rifampicin, get away with rifampicin, add moxifloxacin. Patient not doing well with ethambutol or pyrazinamide, get away, add moxifloxacin. But always use moxifloxacin as a reserve drug because it is the only drug in second line. If you use it as a first line drug, for next 5 years at least, we don't have any good second line drug. So primary, the further trials which are there, like the Remox trial, Thane trial, which are incorporating moxifloxacin in first line. So you have combination of moxifloxacin, rifampicin and pyrazinamide to treat patients of primary sensitive bacilli, and the duration could come down to 3 months. But this is all experimental. We cannot start using them unless it is being approved by US FDA and Indian FDA. So these are all different combinations which are being used over a period of next 5 years to change the standard HREZ regime of tuberculosis. The pill burden, the injection burden, the cost burden is very high in MDR treatment. 6 months of kanamycin, capreomycin or amikacin, along with toxic drugs like cycloserine, hepatotoxic drugs, and severe nausea vomiting inducing drugs like PAS powder. All these things make MDRs more default and then eventually turn into XDR. So as MDR was a man-made disease, XDR is also a man-made disease. To curtail all these effects and side effects of medicines which are very high with second-line drugs, we need to have more drugs which are less toxic, which can complete the duration faster. Patient is okay in 2 months, 3 months of therapy. He did not take it for 2 years. So these are all the trials which are combining the newer analogs and the older molecules for management of tuberculosis. Coming to advances in diagnostics of tuberculosis. Now today, GeneXpert, which is a recommended test worldwide, has changed the diagnosis of tuberculosis. We can get results in 24 hours. It is a PCR-based test of sputum which has a very high sensitivity and specificity. Sputum AFB may not be positive with all labs. You require a microbiologist who is dedicated, who can see 100 fields to report it as AFB negative, which is practically very difficult for an individual when there is a lot of sputum load. You can go to GeneXpert, results in 24 hours. It tells you whether the patient is an MDR TB or a non-MDR TB. So from day one, you know whether you're treating with a sensitive population of bacilli or a resistant population of bacilli. Some other investigations like serological test, IgG, IgM, TB Gold, for example. It's a test which everybody is stuck up with, what to do with a TB Gold positive. Now TB Gold is nothing but a serological variant of Mantu. If a patient is Mantu positive, he has to be IGRA positive or a TB Gold positive. Now TB Gold, the cost is very high. It doesn't give you any fruitful information. If a patient is TB Gold positive, that does not mean he has an active infection. So TB Gold is just your MT. MT is on hand, TB Gold is in blood. It's the same thing. So that is the main confusion which vast majority of our colleagues had. What to do with a TB Gold positive individual? It is same as Mantu positive. IgG, IgM is banned. Don't ever rely on IgG, IgM, and don't even ask for an IgG, IgM in tuberculosis. It's almost out. GeneXpert, excellent results, reliable, no individual variability, no lab-to-lab variability. It is a standard kit given by WHO. Results are very standard. Then you have various of GeneXpert MTB for rifampicin. You have MTB DR plus, that is for INH and rifampicin, and MTB DR SL, that is for your extended and multi-drug resistant infections. Results are very quick. Ideally, it gives results in 2 hours, but depending on the lab load, you may get result in 24 hours. IGRAS, that is your TB Gold test, is again a variant of Mantu, not to be used in our practice unless patient is traveling abroad or wants to undergo an MT test, and you don't want to prick the patient, you can ask for a TB Gold test. Serological tests, they are outdated and discouraged and banned by Health Ministry and DCGI in India. Future would be to detect TB bacilli, the components of TB bacilli like lamb in urine, a breath analyzer test for a TB bacilli, but this is all futuristic medicine. Coming to advances in prevention of TB, now we don't have anything in this. All boxes are empty, except for the baby less than 5 years of age who can get a BCG vaccine, and you can say, chalo, till 5 years of age, you're protected for the thing. Then you have boosters of BCG. Some people recommended 5 years or 10 years, but again, trials don't give convincing results. Nothing for the latent infection, for the active infection. The entire, all boxes are black, except for the vaccine given to a newly born child or an infant. To summarize, nothing new in tuberculosis, same thing which is since last 50 years, 60 years. We just have to use these old resources little more wisely so that side effects are prevented, patient is more compliant with the therapy. Indirectly, you will prevent MDRs. Importance is not to treat MDR-TB, but to prevent MDR-TB. A good chest physician, a good doctor would prevent MDR-TB rather than to treat MDR-TB. Treatment of MDR means XDR-TB. If you treat your primary TB the right way with the right medication, avoiding side effects by using molecules like piperine, which are bioenhancers, which can tackle majority of your side effects in that first 2 months of therapy, you would definitely reduce the load of TB as well as reduce drug resistance in the society. And MDR cannot come directly. It has to be fault of either patient or the doctor. Majority of the time, in first 2 months of therapy, we also make mistakes. We stop some medicines, we feel side effects, come after 10 days, come after 15 days, he doesn't come. He comes after 2 months with an MDR.